We're discussing emergency preparedness with a retired Lieutenant Colonel David Redmond. David, just before the commercial, you were painting a very interesting picture. Finish up your thought there.
Okay, so across all those tubes is your emergency management organization. Your health sector coordinates within its own tube. It takes care of the hospitals, it takes care of your long-term care homes, but its job is not to link to all those other industry, private sector, and public sector. That's why we have an EMO. And the EMO is the one who can give you the global view of what the pandemic is doing across all of your private and public sector continuously on a daily basis. That's their job.
And an EMO being an emergency management organizer?
Absolutely. And every province has one that coordinates across, just like I've said. Every municipality, depending on legislation, has a little EMO in their municipality that reports back to the provincial order of government. And the one in the provincial order of government reports to Public Safety Canada's EMO.
So I've barely heard this phrase, this EMO, being used. Are these individuals, are these departments being engaged with in this pandemic?
In my opinion, if they are, they're definitely not being engaged appropriately. And that was why I started writing letters to the premiers of all 13 provinces in May and my own premier in April, because what I saw was the medical officers of health being placed in charge of a process which A, they're not trained for and never should be. It's not their role. And B, because of that narrow focus, we focused on case counts, not the impact of the pandemic on our jurisdictions.
You're right. I have never seen I didn't even know the name of our chief medical officer of health here in Ontario, where I live, until this pandemic started. Now I think I know his name more than most politicians in this country. It seems they are in charge of this emergency situation in this pandemic. You know, I don't recall, again, another time that I've seen this. Is this a good thing?
Absolutely not, because a pandemic is a public emergency. And these folks are wonderful at running our hospital systems. They're great at running all of the critical care and all that type of thing, but they don't understand the power grid. They don't understand the livestock sector or the food supply sector. It's not their job, and they should never have been trained in it. But what the EMO does is it brings process in emergency. And that process, the operational planning process or the estimate of the situation, is what was missing back in February. We knew in February from world data rolling out of China, Korea, Japan, Italy, and Spain that over 95% of all deaths that were occurring worldwide were in people over the age of 60 who had multiple comorbidities.
Right.
In March, we should have immediately said, where do we have concentrations like that? The answer is obvious, our long-term care homes. If we had quarantined by the middle of March, our long-term care homes and the staff that work in them, we could have saved 17,000 out of the 18,000 deaths we've seen.
Wow. So we would have only maybe experienced 1,000 deaths, which are still, it's a terrible tragedy, but far less than what we would.
It's an awful tragedy, but if you look at it, to date, we have under 600 people who have died in Canada from COVID-19 under the age of 60. In a normal year, context is what's missing in all of this discussion. In a normal year, pneumonia kills about 500 Canadians tragically under the age of 60. So if you compare pneumonia on an average year and the COVID, this is a very bad pneumonia year.
Right. Yep, that sounds like a lot of what I've been reading. You mentioned LTCs. I agree with you. And, most provinces, it seems, had a very similar strategy with respect to LTCs. It seems almost as if we locked not just the patients in the LTCs, but also their caregivers, and everybody was sort of locked into this LTC. Was that even the right approach to lock them down in that regard, though?
The problem is we didn't. If you look at all the way up till May, I'm sure it was the same in Ontario because I think I read it. What we were doing is we were assuming that if we locked the whole public down, the LTCs would do just fine. We didn't quarantine the LTCs and we didn't quarantine their staff. Suddenly you started hearing things like, we're going to tell the care workers in the long-term care homes they can only work at 1 instead of going to 3 because they had, but that still meant those workers were going home at night, every night to their families, catching COVID and bringing it back into the long-term care homes where the people most at risk live.
Right.
So if we had actually quarantined the staff, and by quarantining the staff, I mean provide them with government facilities, all their meals are provided, we move them back and forth. You move them in 14 days before their shift, they do a 30-day shift, and they go home. Another shift then comes in for 14 days pre-quarantine and goes and works. If we had done something that dramatic, and that's not a terrible thing, that's how the people in the oil and gas up in Fort McMurray work all the time. In 30 days, out 30 days. All I'm adding on top is a pre-quarantine for the staff.
Okay.
That would have stopped COVID getting into the LTCs.
I want to pick this up right when we return from this commercial break.